And it turned out when we looked more closely at these women, that the women who had a high senescent cell burden, i.e. the highest tertile for the expression of P16 and T cells, they were all above 70 years. So it appeared that you really don't get high senescent cells, at least in otherwise normal aging women, until after age 70. Now, the converse wasn't true in that we had, more than half the women who were above 70 were still not in that high T3 group. They were in the T1, T2 group. So it says basically to us that to have a high senescent cell burden, you likely need to be above 70, but you could be above 70 and not have a high senescent cell burden. And that could be due to the fact that maybe you're a healthy ager, you're just aging really well, or that you're still aging, but it's not due to senescence. There may be other mechanisms that are driving aging in that particular individual.
Hello, Dr. Khosla. You are a physician and researcher at the Mayo Clinic, leading some of the first human clinical trials on Senolytics for aging and age-related diseases. So welcome to Modern Healthspan, and thank you so much for joining us today.
Thank you for having me.
So, Dr. Khosla, as I kind of mentioned, the Mayo Clinic has been running some of the first human clinical trials for Senolytics. What is the most important thing that you've learned so far that you think people should know?
Yeah, so I think, perhaps I can put that in the context of what we learned from our clinical trial, which was published a little over a year ago. There had been a number of clinical trials, primarily using the combination of drugs, dasatinib and quercetin, which I'll refer to as D plus Q. Dasatinib is a drug that's actually FDA approved for certain diseases, certain hematologic and rheumatologic diseases. And quercetin is actually a flavonoid that is widely available. But at least in cell culture and in mouse models, intermittent administration of D plus Q seemed to be effective in ameliorating a number of age-related pathologies or improving a number of age-related pathologies in mice. And we had done some previous work in mice showing that if we gave D plus Q just once a month, that could prevent age-related bone loss in mice. So we published that study about 7 years ago, and it took us 7 years to get all the initial approvals. And then, we had to deal with COVID, which delayed a number of these clinical trials. So finally, 7 years later, we were able to publish the first randomized control trial and the largest randomized control clinical trial of control subjects versus D plus Q. And this was a reasonably sized trial, 30 participants in each group for a total of 60 participants. Because osteoporosis is more common in women, we studied postmenopausal women all over the age of 60. And this was a kind of a proof of concept 20-week or 5-month study where the D plus Q was given once a month for 5 months. I think one important point is that what we're learning from the preclinical animal models is that senolytics don't need to be given continuously. That very intermittent administration appears to be effective. And this has to do presumably with the fact that senescent cells take weeks or longer to accumulate. So it's kind of the hit and run hypothesis where you just intermittently reduce the burden of senescent cells and still see biological benefits, at least in mice. And that gets around some of the potential toxicities of these drugs because you're giving them very intermittently. So we gave the intermittent D plus Q. And because my primary interest is in skeletal aging, we were looking for a skeletal response as kind of a biological signal. So this was a very early kind of first in human translational study. And we just wanted to know, could we see a biological signal for efficacy? And for that, we measured in the blood certain markers that we can measure for how rapidly bone is being broken down and how it's being formed. And in the overall group of women, we saw a modest signal for an improvement in bone formation. Now, that signal was there, but it was nothing to write home about. But it's important to note that prior to the study, we had hypothesized that the skeletal response to the Senolytic would depend on the initial senescent cell burden, i.e., we had postulated that women with a higher senescent cell burden might have a better response to the Senolytic intervention, which is a plausible hypothesis. So we had used a specific measure of senescent cell burden in peripheral blood. It's called the T-cell P16 assay. I won't go into the details, but based on that assay, when we stratified the women into what we believed was the highest tertile for senescent cell burden versus the lower two tertiles, what emerged was that the women in the highest tertile actually were driving the overall response. So they had a much more substantive improvement in bone formation. And then subsequently, we were able to develop a set of blood markers that were easier to measure, a so-called SASP score. SASP stands for senescence-associated secretory phenotype, which is elevated with our factors that are released by senescent cells. So the women that were in the highest tertile for the SASP score also exhibited the most robust responses to the Senolytic. And then there was a subset of women that were high on both measures, and they exhibited the most robust responses. So we went from, just to put some numbers on it, in the overall group of women to about a 16% improvement in bone formation to when we selected the highest tertile, either based on the T-cell assay or the SASP score, to about a 35 to 38% improvement in bone formation, to when we looked at women who were high on both measures and presumably had the highest senescent cell burden, there was a 60% improvement in bone formation. So using this method, we were able to identify a potential group of responders that really, I think, sets the stage for future trials. And the message, is perhaps not surprising, but we kind of draw the analogy to what's happening in cancer medicine, where the particular drug that's used in a given individual with a given cancer is more and more based on the molecular changes that are occurring in that cancer, the so-called, personalized therapy for cancer. And we believe that aging is perhaps very similar. There are at least 13, if not 4, distinct aging mechanisms, and senescence is just one of them. So what our study would point to is we need to identify whether senescence is a key driver of aging in that particular individual, because we believe that those would be the individuals most likely to respond to a Senolytic intervention. And there may be other individuals who need other types of interventions to delay aging and not necessarily Senolytic drugs. So based on this hypothesis, we're now planning a larger trial to more directly test this idea and look beyond the skeleton, look at measures of frailty, cognition, immune function, cardiovascular function, kind of across all measures of health span. Because, as I say, our initial study was really just looking for a biological signal. Now we want to expand this to more, concrete measures. So I think that's kind of what we learned from our trial. Now, to step back, the overall field, there are many, many trials of Senolytics. D plus Q, fisetin, which is a flavonoid, is also being tested. There have been trials published where more toxic Senolytics, so-called BCL-XL inhibitors, which can't really be given, systemically, but they have been used for using local injection into the eye for a condition called diabetic macular edema, and they do appear to be effective there. So I think people are pursuing many different directions, all the way from kind of a total body treatment, systemic treatment using drugs, to local injections into the eye. But I think the underlying principle that we've learned from our study is that as we interpret these trials, many of them may be negative because they may not have stratified appropriately for the people with a high senescent cell burden. So it just highlights that going from mice to humans is not simple, that there are going to be many stops and starts. And I think our trial is just an example of what we learned and how, it wasn't the definitive trial, but we learned a lot from it, and how that will inform future trials, both by our group and other groups.
So the women had very kind of varied levels of senescence. And the two tests you were doing are basically trying to measure the same thing, which is the systemic level of senescent burden, right? But they're just doing it in different ways. Would that be correct?
They're complementary approaches. One is harvesting blood cells, T cells, and measuring the expression of a particular gene, P16, in those cells. And it turns out that that is correlated to these blood protein measures that we've identified, the SASP score. So they're interrelated, but it appears that either could be useful in identifying the women with a high senescent cell burden. Now, clearly, the SASP score, which is just based on blood measurements of proteins, is much easier to do than the more cumbersome T cell assay. And the other point I'd like to make is that, we studied women over the age of 60. And it turned out when we looked more closely at these women that, and this was mainly using the T cell assay, that the women who had a high senescent cell burden, i.e. the highest tertile for the expression of P16 and T cells, they were all above 70 years. So it appeared that you really don't get high senescent cells, at least in otherwise normal aging women, until after age 70. Now, the converse wasn't true, in that we had, more than half the women who were above 70 were still not in that high T3 group. They were in the T1, T2 group. So it says basically to us that to have a high senescent cell burden, you likely need to be above 70, but you could be above 70 and not have a high senescent cell burden. And that could be due to the fact that maybe you're a healthy ager, you're just aging really well, or that you're still aging, but it's not due to senescence. There may be other mechanisms that are driving aging in that particular individual.
Was there any way for you to tell without looking at the blood? I mean, I know because it's a study, you need to look at the blood, you need to have this detailed analysis. But was there anything else that you could look at and say and estimate whether a person would have a high senescent burden or not?
So we haven't looked at, we didn't really do a very careful kind of clinical evaluation of these participants, other than, screening them for cancer or other diseases. And they were otherwise community dwelling, reasonably healthy older women. So the only thing that emerged was age. So, age above 70 was something that enriched for these women with a high senescent cell burden. Now, in future studies, we plan to do a much more detailed clinical phenotyping of these women. For example, did they have greater frailty in some way? Did they have other clinical features that might, identify these women as potentially having a high senescent cell burden? So right now we're relying on these blood biomarkers, which I still think in the end are going to be the most reliable measure, but we're trying to find clinical correlates for those.
Are you aware of any commercial test that people could take to estimate senescent cell burden?
I mean, there is a company I believe it's in North Carolina, that, and I'd have to look up the name, but they do offer.
Ginfinity? Is it Ginfinity?
I can't recall, but
okay.
They will measure the T cell P16 levels for you. Now they use we modified the assay that they're using because it worked better in our women over the age of 70, but they're related measures. But that's the only kind of commercial entity that I'm aware of that right now will give you some measure of senescent cell burden.
Just, is there any other way? Is there any way of telling
Yeah.
whether a person has high senescent cells?
I mean, at this point, unfortunately, I would have to say not in a reliable way. We know risk factors. So we know that, as I said, if you're older, particularly above age 70 from our cohort, obesity tends to increase the burden of senescent cells. Smoking tends to increase the burden of senescent cells. We know people who have received chemotherapy, at least for some time after that, may have a higher burden of senescent cell. And probably chronic HIV infection appears to be perhaps related to an increase in senescent cells. I mean, those are kind of the risk factors, but having a reliable way to identify those individuals is, I think, an important need for the field, both for identifying participants in clinical trials, but also potentially for over time, once they're validated, for general use by the public who are maybe interested in knowing another measure of aging in addition to what's currently available in terms of some of the biological clocks that are out there and so forth.
So just on the trial, so the patients took, well, the participants took dasatinib plus quercetin, and it was every 2 weeks. And what were the dosing?
Yeah, so it was every month, every 28 days. And it was dasatinib was 100 milligrams per day for 2 consecutive days. We had wanted to give it actually for 3 consecutive days, but the cost was so much that we had to limit it to 2. And the quercetin was 500 milligrams twice a day for 3 consecutive days. So in the future trials, we're going to propose dasatinib 100 milligrams per day for 3 consecutive days, and the quercetin 500 milligrams twice a day for 3 consecutive days, repeated every 28 days or roughly once a month.
In terms of the currently available Senolytics, so for the next trial, you are planning to stick with dasatinib and quercetin, so not fisetin or anything else?
Based on our data, I mean, in my view, if you look at the published clinical trials, and here I would emphasize that, my perspective is that you need to have a control group. There are trials there that will study somebody before and after drug administration. But, without a control group, I think it's very difficult to say anything about efficacy. So my own bias is that if you look at the controlled randomized trials, the only data that's out there for efficacy right now is for DQ based on our clinical trial. There are a number of studies out there with fisetin. There's no published randomized control trial as yet on fisetin. There are observational studies with fisetin which have looked at different biomarkers for people who are voluntarily taking fisetin versus people who are not. And that can generate hypotheses, but in my mind, that's not sufficient evidence to actually invest in a clinical trial beyond kind of an early phase proof of concept trial.
During the trial, did you look at the senescent cell burden with your tests, kind of in an ongoing basis? So you were looking for this protein associated with bone reabsorption or bone formation. Right. But did you see the senescent cell burden change as well?
So there were a number of kind of in part because the study was done during COVID and for funding issues, we were unable to get follow-up kind of assays in terms of the T-cell assay. We did look at our SASP score, and even though that SASP score was useful in stratifying participants, to identify the ones with a high senescent cell burden, with our treatment, we couldn't demonstrate changes in that SASP score. So that's an important unanswered question, is how do you follow these participants? Now, in a previous study that had been done by Dr. Kirkland, and we had collaborated on that, they had used a similar dosing regimen of D plus Q, in patients with diabetes-related chronic kidney disease, and they had gotten skin biopsies before and after D plus Q. And on the skin biopsies, they were able to show a reduction in senescent cells. So we have some evidence that this dose is effective, but based on our work, my concern is that that may not necessarily be reflected in the peripheral blood, and you may actually need tissue biopsy specimens to actually, address that question.
Why both dasatinib and quercetin? Do they kill different kinds of cells, or why do you need both?
Yeah, that's based on the original work of Dr. Kirkland, who really does need to be credited for the kind of the initial kind of identification of D plus Q as a senolytic combination. And that was based on his original paper, where in culture they looked at different cell types. And it appeared that for certain cell types, dasatinib was effective. For other cell types, quercetin was effective. And, to get the broadest coverage across tissues, the combination of D plus Q seemed to be the most effective. So it's really kind of the idea of, we think of antibiotics trying to get broad coverage against different types of bacteria. I think in that same way, D plus Q is a way to get broad coverage against senescent cells in different tissues, if you will.
So thinking about bone health, because I think bone health, as you mentioned, skeletal health is kind of your speciality. How do senescent cells contribute to osteoporosis and the kind of the weakening of the bones?
Yes, that's a really important question, and we're actively pursuing that. One of the interesting things that came out of this is that there's perhaps an interesting link between Senolytics and an FDA-approved drug for osteoporosis, romosozumab. So romosozumab is an antibody that is administered to humans against the protein called sclerostin. Sclerostin is a protein produced by bone cells that inhibits a pathway known as Wnt signaling. So it turns out that activation of Wnt signaling is really important to stimulate bone formation and reduce bone resorption, basically to protect the skeleton. So by using an antibody to sclerostin, you inhibit the inhibitor, so to speak. So you activate Wnt signaling and you stimulate bone formation. Now, in our animal models, we were finding that when we gave a senolytic, it was reducing the levels of sclerostin messenger RNA in bone. And the profile of changes in bone formation and bone resorption following the senolytic is qualitatively very similar to what you see with romosozumab. So we think that at least in bone, part of the effects of the senolytic may be through inhibiting sclerostin and activating Wnt signaling in bone, which is protective for bone. And, the advantage of senolytics over romosozumab, would be that romosozumab is specific for bone, whereas senolytics, presumably, and this is what we need to continue to test, would have benefits not just for bone, but also potentially on frailty, on cognition, on immune function, on a whole host of other conditions by clearing senescent cells across tissues.
Why do senescent cells inhibit the kind of the growth of bone or the maintenance of bone?
Yeah, I think that's a really kind of difficult question to answer. What we know is that across tissues, including bone, senescent cells develop a inflammatory phenotype, the so-called senescence-associated secretory phenotype. And that's just a byproduct of the DNA damage that occurs, prior to developing senescence. And that damaged DNA triggers an inflammatory response, presumably to attract the immune system to clear those cells. But particularly with aging, the immune system becomes less effective at clearing those cells, so these cells, tend to accumulate. But a byproduct of that inflammation is detrimental effects on many tissues, including bone. So we know that there are many inflammatory factors that senescent cells make that in other studies unrelated to senescence have been shown to increase bone resorption and decrease bone formation. So I think the link to bone loss is really through this inflammatory pathways that are activated in senescent cells.
So if you're like a 60, 70-year-old lady and you see that you have low bone density, but it could be many things, right? It need not necessarily be related to senescent cells. Would that be correct?
Yeah, I mean, for example, in women, perhaps the major trigger for bone loss is the menopause and estrogen deficiency. And, that occurs in their 50s, probably well before there's a marked accumulation of senescent cells. So, I think the early bone loss between age 50 and 70 in women is likely driven by estrogen deficiency. And then senescence becomes a more important factor in age-related bone loss, probably after the age of 70. So, it just highlights that a condition like osteoporosis doesn't have one single cause. Senescent cells likely contribute, but probably in older women and perhaps in a subset of those women.
So if we think about what people can do now, right? We kind of talked about being able to measure it, and that seems somewhat difficult at the moment. But if you were concerned about senescent burden or even for bone health in general, so what can people do now? Is dasatinib plus Questin available for just regular people?
I mean, quercetin, you can buy it from health food stores. Dasatinib is a prescription drug which has potential toxicities. It can affect blood counts and so forth. So I, at this point, would not recommend using dasatinib until we have more evidence about efficacy and long-term safety. I don't personally believe that quercetin on its own, especially without identifying the patients who really might benefit from it, is going to have major efficacy on its own. So for the average person, who, unless they're in the context of a clinical trial, I would not recommend going out and starting dasatinib and quercetin or even fisetin, because I just don't think we have evidence, right now for efficacy of fisetin, and even the efficacy of D plus Q. Right now, all we have is a biological signal from our clinical trial that needs to be refined and tested further. What I would recommend is certain things that are available. So, starting with lifestyle, it's pretty clear that in humans also, moderate exercise reduces senescent cells, that modest caloric restriction reduces senescent cells, that other lifestyle things that we already know are good for you, such as not smoking and so forth, is beneficial. Now, beyond those lifestyle measures, there are, some potential avenues that, especially if you have another disease where you need to take these drugs, might be beneficial. So, for example, if you have prediabetes or diabetes, there is some evidence that metformin may have an impact on senescent cells. It probably doesn't kill senescent cells, but it's what we would call a xenomorphic. It reduces the secretion of the SASP. So, that would argue that if you have prediabetes, for example, and are, particularly older, over age 70, you might consider metformin both to reduce the progression of the prediabetes to diabetes and potentially to impact your senescent cell burden. There's some evidence that the osteoporosis drug, zoledronic acid, may have benefits on senescent cells and may reduce mortality beyond just reducing fractures. So if you have osteoporosis and are concerned about senescent cells, zoledronic acid might be a reasonable choice based on what we know, because you're primarily treating the osteoporosis, but there is some evidence that that may also reduce your risk of heart attack and cancer and so forth, in part through effects on senescent cells. Now, of course, there's a lot of interest right now in the GLP-1 receptor agonists and whether, they have anti-aging effects. And I think the jury is still out on that in terms of in my mind, in terms of the true anti-aging effects of those drugs, and whether those effects or those benefits of those drugs are mainly through weight loss, or whether they have some independent effects as an anti-aging drug. I think the answer could be either one.
But if they do, well, they do reduce weight. And so in general, reducing adiposity, reducing fat would reduce senescent cells, we believe.
Right. Yes. The question is whether they have benefits independent of the weight loss. Are they affecting other pathways that are anti-aging, distinct from their effects on weight loss? That's a difficult question to answer, but and it's mainly relevant to people who might want to take those drugs who are not overweight, which I think is, so if you're obese and you want to lose weight, the GLP-1 drugs have a great rationale. But if you're not obese and you don't have diabetes or prediabetes, I don't think there's good enough evidence that you take the GLP-1 agonist, for anti-aging, in that situation.
Are there any symptoms that would imply that you have elevated senescent cells? So, I mean, we did talk about measuring. Yeah,
right.
We still don't have a good answer on that. But apart from, are there any symptoms that you could look for?
There are no specific symptoms. I think it's reasonable, although this hasn't really directly been tested, using some measures of senescent cell burden and other Healthspan measures. But I think it's plausible that people who have multiple comorbidities, multiple age-related diseases, who have frailty, that, a significant proportion of those individuals likely have increased senescent cells. But that's speculation. I don't know of any good data testing that.
And at the moment, even if you work with a doctor, there are no like FDA approved drugs for Senolytics, correct?
I think the only thing is what I mentioned. There are FDA approved drugs that are used for other conditions like metformin that may have effects on senescent cells, but there are no FDA approved drugs. I think the other thing I want to point out is that until we did our clinical trial and really tried to develop some of this idea of personalized medicine, which others have suggested also, it's not unique to us. But I think the thinking in the field was that in general, there was an accumulation of senescent cells with aging, and that virtually everybody who got older would have high senescent cells. And I think what our data suggests is that that's not necessarily true. So it adds this new twist that it's really imperative to develop biomarkers for identifying those older individuals who truly have a high senescent cell burden.
So one of the things that you did talk about, so you wrote a paper recently kind of looking at reviewing the current status, is kind of the next generation of Senolytic cells, Senolytic products. Is there anything you can say about them? Do you know how close are these to actually being used?
Right. So, right now, I personally think that DQ is, not the best Senolytic combination, but it's the best we have right now for further testing because it's shown some efficacy, it's shown safety, and we need to learn more about it. Now, other data may come out, and again, I emphasize, I would really urge the field to have control groups. Without a control group, I think it's very difficult to judge efficacy. So I look forward to randomized control trials of Herceptin or other Senolytic drugs. I believe that, more potent but potentially toxic Senolytic drugs may be developed, are continuing to be developed for specific local indications. So this would be for specific diseases like I mentioned, diabetic macular edema or osteoarthritis in the knee. The early trials with those have shown some signals for efficacy, but for example, the company that was developing the drug for the eye, recently, restructured and may have kind of ceased to exist because they couldn't prove that their drug was better than what's currently being used. But that doesn't mean that their study wasn't useful because it did show that these drugs do work in the eye. It's just that they weren't necessarily better than other approaches that are being used. So as a proof of concept, I think it was valid. So in my mind, there's kind of two different approaches that probably need to be pursued. One is continued development of new drugs that can be used locally that are highly effective for specific conditions associated with high senescent cells. And the ones that come to mind are in the eye, in specific joint diseases. There are a number of companies pursuing application to the skin to improve wound healing, for example, or to reduce skin aging. So because the skin is so easily accessible and you can minimize the absorption of these drugs and potential systemic toxicities, the skin may be another area where these will be developed. On the other side, systemic drugs, I think right now, probably DQ is what we have, pending further data. And I think there we do need more drug discovery and identification of newer drugs that are specific for senescent cells without causing toxicities. And that's where a lot of work needs to be done.
So you can have kind of local areas in your body, like in the eye or whatever, which has a high senescent burden, but then the rest of the body could be like not have this high senescent burden. So I guess, is that true? So the senescent burden could be unevenly distributed throughout the body and would have different impacts on different tissues.
Yes, we're learning more and more that that's the case. I mean, there probably is, in a subset of people, a gradual increase in senescent cells across all tissues. And, those would be the ones that might respond to a senolytic with an overall improvement in multiple functions. But there could be people, for example, in their 60s with Alzheimer's who have high senescent cells in the brain, but not necessarily everywhere else because they have a very specific pathology in the brain that's associated with triggering senescence. So I think senescence can be viewed as something that occurs, perhaps in a substantial proportion of people just with aging, but also in association with specific diseases that trigger senescent cells. And these could be, Alzheimer's, atherosclerosis, in certain individuals may be associated with a local increase in senescent cells, certain types of kidney disease, for example. So there may be both systemic and tissue-specific increases in senescent cells. And again, we have to learn to identify, in a given individual, what's going on. For example, there may be, we could develop protein biomarkers that say, well, this individual, based on this blood protein or lipid profile or whatever, has an increase in senescent cells across tissues. Another individual could say, well, this protein profile suggests that this individual really has mostly an accumulation of senescent cells in the brain. Because the other thing we're learning is that the SASP, or the inflammatory phenotype of senescent cells, in different tissues is very different. So the senescent cells in the brain could secrete very different inflammatory factors from senescent cells in the blood vessel, for example. So we may be able to identify individuals with high senescent cells in specific organs or tissues.
Do you think it's ever going to be possible to rescue senescent cells? I'm just thinking about Alzheimer's. I mean, if you have senescent neurons and all you do is kill them, then that may not be the best option.
Yeah. I mean, I'm not aware in the context of aging of reversing senescence. It's always felt to be an irreversible cell fate. Now, there are some recent examples from the cancer field where certain cancer cells may revert to a non-senescent state. And, that's been described, but I'm not aware of that in the context of aging. Uh, I think the other thing to keep in mind is that those senescent neurons are really not doing the patient any good. And, so killing them may not be the worst thing because they're doing more harm than good because they're secreting the SASP, which is, impairing the function of the normal neurons. So by killing those senescent cells, you're going to improve the function of the remaining neurons and presumably improve overall cognition.
Yeah, and since the senescent cells are the SASP is different from the different cells, then hopefully we could get to a point where you could, from a blood draw, you could estimate what kind of cells are senescent and where they are and how much of them.
Exactly. I mean, and that doesn't seem that far-fetched. I mean, there's recent evidence, for example, not specifically for senescence, but based on blood proteomic analysis, different groups have been able to identify what they call accelerated aging phenotypes in a tissue-specific way. So again, this is not specific for senescence, but more broadly, there are biomarkers that potentially identify accelerated brain aging versus accelerated kidney aging. And so we're already getting, towards that goal.
That would be, yeah, that would be very helpful. That would be.
Right.
Should women think about senescent cells differently from men? Do you think there's a lot of sex specificity in it?
That hasn't been studied, to my knowledge, very carefully in humans as yet. In our mouse models, generally, we don't see large differences based on sex. The senescent cells seem to accumulate with age in mice in both sexes, and both sexes seem to respond to senolytic interventions. When we've carefully studied bone, it appears that there may be an earlier accumulation of senescent cells in males rather than females in mice. But an important caveat is that mice don't have the menopause. So we don't really know how in humans the menopause might accelerate the development of senescent cells, in women. I mean, for example, it's known that women have for a given age, women have a higher incidence of dementia or Alzheimer's. And is that in part due to the menopause and estrogen deficiency? And does that actually then lead to more senescent cells in the brain in women? So I think it's very difficult to kind of extrapolate from the mouse studies on sex differences simply because the mouse really doesn't become, the female mouse doesn't become completely estrogen deficient like the postmenopausal woman does.
We should be able to look at senescent cell. I mean, it would just be an observational study, but we should be able to view the senescent cell burden of women based on their menopausal status. But I assume that hasn't been done. Like
That's not been systematically examined. I think that's an important research need. Yeah.
Yeah. Okay. I mean, it doesn't seem very invasive. It's just a small blood draw.
Yeah.
Can I ask, do you have a personal protocol and do you take any Senolytics?
I don't. Again, for the same reasons that, I've outlined to you, I think efficacy and safety still need to be established. That said, I do the other things. So, I exercise for 30 minutes every day. I, try to maintain a BMI at the low end of normal, particularly for an Asian Indian, where we tend to get visceral adiposity at much lower BMIs than Caucasians do. And then I do the other things, not smoking and, try to be physically active. So I do all the lifestyle things that I can, but I don't specifically take a senolytic.
For bone, how important is weight-bearing exercises?
It actually is quite important because weight loading helps maintain normal bone. And in fact, we just had a study that came out in collaboration with Dr. Alex Roebling, who's at the University of Indiana. And he's shown in mice that in aged mice, if you clear senescent cells with D plus Q, you actually enhance the skeletal response to mechanical loading. So there may be some interesting interactions between senescent cells and loading that, loading, the benefits of loading may be enhanced if you can reduce senescent cells, at least in the mouse model.
You said that dasatinib and quercetin deal with different senescent cells. Do you know which one of them is most effective for bone cells that are senescent?
We haven't individually studied them, but I think in general, based on the cell culture studies, I would say that in the D plus Q combination, the majority of the effect is probably through dasatinib, and the quercetin is adding a little bit overall.
Right. So is it actually the bone cell, like the piece of bone that becomes senescent, or is it the material around it?
So, bone has many different types of cells. There's the osteocyte, which is embedded in bone, that actually structurally is very similar to neurons in the brain. And that cell has, these dendrites that kind of talk to other cells in bone. Then there are bone-forming cells or osteoblasts. There are osteoclasts that resorb bone. And of course, bone is surrounding the bone marrow, which contains immune cells and all sorts of other cells. So there are probably multiple different cell types that become senescent with aging. And we believe that the osteocyte is an important one, kind of like the neuron, but there are probably other cells, some precursor cells that also appear to become senescent. So it's the cells that are becoming senescent, but with aging and likely also with the inflammatory SASP, that does then lead to secondary changes in the bone matrix. For example, with aging and with diabetes, for example, we know that advanced glycation end products accumulate in bone, and they tend to weaken bone. Now, that's independent of senescence, but it's possible that the AGEs are triggering senescence in certain cells. So there are very important interactions potentially between the cells in bone and the extracellular matrix in bone. And that's probably true not just in bone, but in the brain and the kidney and everywhere, where it's not just the cells that are aging, it's the matrix that's aging. And then the interactions kind of produce almost like a feed-forward loop where they, just make this whole situation worse.
Would there be any problem in removing all our senescent cells? Do senescent cells perform any function for older people?
Yeah, I mean, historically, senescent cells were felt to be important for wound repair. That was one of their beneficial functions. And there is evidence in mice that, if you clear senescent cells, you may delay skin healing somewhat. On the other hand, there's also evidence in mice, and there's some human clinical trials now, that if you have a non-healing wound in the skin, that those senescent cells may be contributing now to the non-healing. And if you clear those senescent cells, it may improve wound healing. We've also found, at least in mice, that you get this acute increase in cells that are expressing features of senescent. We call these injury senescent cells. And actually in mice, if you reduce the burden of those senescent cells, you actually improve fracture healing. So, there have been beneficial effects of senescent cells that have been postulated, but that seems to be very tissue specific. The other beneficial effect that's been postulated, is that it's an anti-cancer mechanism with aging. So when a cell has DNA damage, the idea is that instead of becoming a cancer, they activate these senescence pathways and become growth arrested. But at the price of aging because they're secreting, this SASP. But again, the situation is more complex because there's now evidence that if you have a cancer, the senescent cells in the surrounding stroma actually promote cancer growth by virtue of the SASP. So, I guess in that context, senescent cells are complicated. We know that they contribute to aging. Under certain circumstances, they may have beneficial effects, but that's very tissue and context dependent, I guess.
So in the preclinical trials, did you see any increase in cancer or even a signal of an increase in cancer when you were running the Senolytic trials?
No, in fact, Dr. Kirkland's group had a nice paper originally with DQ that treatment of mice with DQ not only increased measures of frailty and other things and skeletal benefits as we've shown, but it also increased lifespan in the mice. And there was no increase in cancers in those mice. And I think, again, I come back to the intermittent administration. So because the senolytic drugs can be given very intermittently, you're actually probably not preventing that anti-cancer mechanism because you're not preventing the senescent cells from forming as an anti-cancer mechanism. You're just kind of intermittently reducing the burden of those senescent cells and the detrimental effects that those have. So I believe, although we still need to do the studies, I don't believe that clearing senescent cells intermittently will increase cancer risk, but I think it'll still have beneficial effects on aging.
Yes, that makes sense. If senescence is an alternative end fate for a cell rather than cancer. I mean, once it's decided, okay, I'm going to be senescent, then it's not going to go on to be cancerous, and so clearing it at that point, it would make sense. Doesn't initiate cancer. As we kind of wrap up, so any advice for people on how to? I think we've covered a lot of things, but any advice for people how to maintain a low senescent burden?
Yeah. So actually, I'd like to close with a couple of thoughts. So I think right now for a low senescent cell burden, as I say, I would not take D plus Q. I would probably not take Fisetin. We just don't know efficacy and safety. I would focus on the lifestyle measures that I've talked about: exercise, modest caloric restriction, healthy lifestyle features. And again, if you have a condition that requires a drug, think about whether that drug has been shown to have any efficacy on senescence, like, for example, metformin or potentially for osteoporosis, zoledronic acid. To me, right now, that's the wisest course to take. And it's going to take time. I mean, before we can really learn about the right patient populations, the right biomarkers, the right drugs. The other thing I guess I want to stress both to kind of the public and my scientific colleagues is I think, there was a huge amount of hype on senescent cells and a large number of kind of trials. And I think we need to kind of tamp down the hype a little bit. I believe at the end of the day, senescence will be an important aging mechanism, but it's not going to be the answer to all of aging. And it's not going to be the answer to everyone's aging. So I think, it's an important pathway related to aging, just as, for example, epigenetic changes are, or telomere shortening are. I mean, there are multiple mechanisms of aging. So I don't think we want to hype up senescent as kind of the elixir of youth. I think it's going to be one among many different aging mechanisms. We need to continue to, push the scientific frontier so we understand it better. And we need to kind of, in a systematic and careful way, with appropriate stratification of patients, begin to translate it carefully into humans and not expect that every clinical trial is going to work because the right patients may not have been selected, the drug may not be efficacious in that condition, or as happened to Unity, it may work, but it may not be better than an established drug. So I think, you have to keep all that in mind. And, there are people who are ardent supporters of senescence and Senolytics, and there are people who want to kind of trash the whole field. And I would encourage a middle of the road approach where, like any scientific endeavor, it is full of nuance and complexity.
Especially biological. Yes. So you said you were thinking of you're working on a new trial, right? Based on what you learned from the first one. Any idea on timescale of when you're going to get it started, how long it will take?
Well, obviously, as an investigator in the US, we have to get our studies for these kinds of clinical trials funded by NIH. So we have just begun some initial conversations with leadership at the National Institute on Aging. And we're in the process, myself, Josh Farr, who's now at the University of Arizona, who did a lot of these clinical studies and preclinical studies with me, and Nathan Lebrasser, who's my colleague here at Mayo, who's the director of the Aging Center. So the three of us are, actually, interestingly, just having one of our ongoing meetings this afternoon to brainstorm about the design of the trial, what endpoints we want, how many participants would we need? Would this be a single site or a multi-site trial? And then we have to kind of come up with a budget and then discuss with the National Institute on Aging and get their feedback. So we're hoping we can submit the grant application by June of 2026. And then, depending on how the peer review goes and so forth, perhaps initiate the trial in the next year or so.
Okay. So how can people follow your work and follow how you're doing with this trial?
Right. So, the COGOT, so I'm not particularly active on social media. I don't post a lot. Certainly, PubMed searches on my work or my colleagues at the Center on Aging. The Mayo COGOT Center on Aging does have a LinkedIn page. So if they go to LinkedIn and follow the COGOT Center on Aging, the center on my behalf and on behalf of other investigators in the center will post recent advances from our center on LinkedIn. So that's kind of the main ways to kind of follow, other than kind of through publications that come out in PubMed and so forth.
Okay, excellent. Thank you. I will find that and add a link to that in the description.
Sure.
Okay, Dr. Khosla, thank you so much for joining us today. It has been great talking to you.
My pleasure. Thanks for taking the time to visit with me.
Thank you.